The topic today is long-term mortality after acute myocardial infarction, the good news and the not so good news. Look, we've just lived through one of the most remarkable periods of progress in cardiovascular care. Acute mortality for acute myocardial infarction has dropped dramatically over the last 20 years or so. The elevations in that quality of care over these last 20 years has reduced mortality by about 20%. And this was at a time when, because of better prevention and population health-based approaches, we reduced the actual incidence of acute myocardial infarction by about 30%. So fewer people coming into the hospitals with heart attacks and more people who are coming in with heart attacks surviving. But a question has emerged. So we've known very well that we've had this reduction in mortality, but what about the long term? We've saved a lot of lives early, but did we lose ground in the months and years after that? So as we helped more people survive, were those people sicker? Were we only postponing the inevitable, or was it able to be sustained? So this was a question colleagues and I addressed. We sought to look at 20 years of Medicare data, a comprehensive look to see what happened. And one of the things we considered was maybe if you start looking at survivors 30 days after their hospitalization for acute myocardial infarction, maybe over time, mortality has actually increased. Because like I said, those people who have survived tend to be frailer, higher risk. Maybe there wasn't much we could do. And that over time, that mortality might have increased. Now, our hope was that at least the gains would be sustained. So if we looked at among survivors and looked at their long-term outcomes, we would see that it hadn't changed much over time. And that would represent a victory because we knew we were saving lives early. And if we didn't lose lives later, that is over time, we were able to maintain that gain, then that's a win. But then we harbored another hope. We thought, well, maybe we're actually amplifying those early gains because not only are we doing a better job early, but we've also increased the use of statins and we've emphasized secondary prevention to a greater extent. And we're doing better, not optimally, but we're doing better at ensuring every patient can get the best care possible and have the best chance to have their long-term risks reduced. So we took a look at this. We included almost 4 million Medicare beneficiaries hospitalized from 1995 to 2019. And of course, when we're looking at 10-year outcomes, we're looking at people who had at least 10 years of follow-up, but we're also looking in the later years too. We've looked at that as well to see whether or not these trends are being maintained. And we focused on people, like I said, who survived at least 30 days after their acute myocardial infarction. So that was the starting point, survivors. They made it at least a month. And now we're looking at what happened after that. And so there's good news and some not so good news. So what's the good news? So there were definitely improvements. So remember I said that, would we lose ground? Would we have maintained the ground? Well, we actually even made more ground up. We were saving more lives over time. And that long-term follow-up among the survivors. The adjusted annual 10-year mortality rate actually decreased over that period by about 1.5% each year. And that adds up. The risk of 10-year mortality was about 14% lower for patients hospitalized between 2007 and 2009 compared to those hospitalized in 1995 to 1997. We're making up ground every year. And we also looked at the risk of recurrent acute myocardial infarction. That dropped about 2.7% each year. And the risk of 10-year recurrent MI was 22% lower for that group hospitalized between 2007 and 2009. Again, remember to get the 10-year follow-up, 2009 takes you to 2019. So that was the last group we could look at that we had complete follow-up on. But it was 22% lower than those who had been hospitalized in 1995 to 1997. So we're doing even better. That is, we knew we were dropping the acute mortality, but this long-term mortality among the survivors is also getting much better. But amid all this good news, there was also some news that gave us pause. The risk of recurrent AMI over the 10 years after the initial hospitalization is still rather high, almost 1 in 4. So even though the rate was dropping, there still remains a frontier of improvement because we think that with many of our tools, we should be able to really push down that risk of recurrent MI. And so we can probably do better. There's also studies that suggest that we're not yet at the optimal levels of all the tools that we have to reduce risk. And we've got more tools coming. SGLT2 inhibitors, the GLP-1 agonists. There will be more that in our armamentarium. Plus, we can be pushing lifestyle modifications probably to a greater extent. Now, these are older patients. Things are going to happen over time. Risks increase with age, but it's an aspiration, I think, still that we can do better. And then the most concerning thing out of this study was that we saw that there was issues of health inequity. Black Americans, those who were dual eligible, that is Medicaid, Medicare, so patients who are poor, and those who are living in priority areas that persistently have worse outcomes over decades. And this is highly concentrated within the South. People in those three groups all had persistently worse health outcomes. Their survival was worse over time. So there were improvements for all groups, but gaps were persistently there, suggesting that we can be doing better. And this is also true for the recurrent MIs. So what's this mean? Well, clinicians and their patients have reasons to celebrate. Acute myocardial infarction outcomes are improving. We know they're improving early. This is evidence that even 10 years out, we're seeing better outcomes. We don't lose ground. We actually gain ground over time. We're doing better. But we have areas to improve upon. People after AMI remain at high risk. There's still many people who are having recurrent acute myocardial infarction. We can probably do an even better job by giving patients an opportunity to reduce risk. We can do that with medications, lifestyle modifications. I'm sure that we can achieve even better. And we need to commit to solving the problems of health disparities and recognize that race and income and even geography remain important risk factors. And we have to figure out and solve this issue so that we can ensure that each person, regardless of who they are and where they live, has a chance to get the very best outcome. And these health inequities, we got to get rid of them and figure out how best to approach this so that each patient can get the best outcome possible.